Yeah. Good morning and welcome. We'll call to order the Board of Health agenda for October 30th, 2024. Mr. Ibach, do we have any guests or?
We have one guest.
Jennifer Maxwell, family physician. Thank you.
Good morning.
Mm.
Any public comment today?
No public comments.
So Jennifer, would you like to make the comment? Okay, thank you. We'll move into the consent agenda. All items listed below the bullet point are considered routine by the health board and will be enacted by one motion. There will be no separate discussion of these items unless a board member requests, in which event the item will be removed from the consent agenda and considered in small sequence on the agenda. So, give me the agenda, please.
Yes, September 28th, 2024, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in September 2024 in the amount of $954,829.83. Payment to Chuck Redifer in the amount of $4,320 for a septic system relocation.
Does anyone have a desire to review the item from the agenda? Right, I understand the motion to approve.
Motion.
We have a motion and a second to consent agenda as presented. All those in favor, please say aye.
Aye.
Any opposed? Motion passes. Thank you. Next is the Yakima Health District Spotlight. This development is able to update, presented by Cecile Ensign, Development Disabilities Coordinator.
Thank you. Good morning, everyone. Nice to see everybody here. Wanted to give an update on the DD program and more importantly on our work that we've been doing in transition. So high school transition is, well, let me back up just for a second. We've talked about the three programs that really the DD program is made up of. The Birth to Three program, we talked about the employment services that we provide, and then the Job Foundation program that we have for the high school students. Well, a part of the Job Foundation program sits in high school transition. And what transition services are is they help students with disabilities prepare for transition from their school years into adulthood and workplace and or in some instances education. The high school transition program is with teams. There's a transition team for each student, their student and family, their health district staff support here, and then they work with DVR and DDA to get the student ready for their next phase in life. The schools offer something that's called pre-ETS or pre-employment transition services. What is involved in this program? It's typically from age 16 to 18, 19, and it starts teaching the students about job exploration, about being self-advocates for themselves, getting them ready for work, and then talking about post-secondary education as well, if that's what they're interested in. And the goal is to help students start thinking about their life after school, what they want to do, have a plan. And with our Job Foundation program, we're hoping that many of them will have employment by the time they get out of school. So our Job Foundation program that we've been working on for about 3 years is an integral part of this. It engages the students, it connects them, and it helps them start planning earlier for their second to last years in school and then later on for life. It occurs through the development of the Job Foundation report that they work to create with a job coach. And the benefits are for Job Foundation, it provides the Job Foundation report. It has expertise with the DDA and DVR case resource managers, and it's a partnership that increases results. It also helps the students leave school with a guide, with an idea of where they want to go, and with hopefully a job. So this last year in February, we decided we were going to add someone to our team to help with these efforts, to be out in the schools. So many of the schools can teach the first couple of years of transition, but they really don't have the expertise they need to help guide the students where they need to go. And so we added Daniel Bravo to our staff, and he has been a great addition. It added more staff time for the developmental disabilities program. He is bilingual and he is able to reach out to so many families. 50% of our population is Spanish speaking only. And so it's really important for us to have somebody that can communicate with these families. And it just gives more opportunity to outreach to schools. And they really need the outreach right now because a lot of them aren't meeting their transition goals. So Daniel has been out in the schools. He's been educating teachers. We had an educational session this last August before school started here with a couple of our teachers that helped spearhead this. And we had about 8 school districts, I think, here. And then we continue to have outreach in the schools. So far since Daniel's been on, we had outreach in May, June, August, and then October. Last night we were down in Sunnyside and made some good connections down in Sunnyside. Just to give you some comparison between how we were doing in job foundations before this year, in 2022 and 2023, when we were rolling out this program, we only had 4 students across the county that took advantage of this. And as of yesterday, Daniel had 2 more sign up. So we've got 18 students so far in this program this year. So we're really excited with him being out in the schools, how many more students were able to sign up for this program. We only had 4 school districts. We had lots of meetings, tried to meet with a lot of schools, but we only had 4 different school districts having students in job foundations. We're up to 11, and I'm pretty sure that's going to be 12 in the next week or so. After visiting with Sunnyside, we were able to talk to their SPED director last night. He really didn't understand a lot about the program till Daniel and I were able to talk one-on-one with him. So it was kind of an exciting night for us. We have been increasing our partnerships, like I said, with the schools, with the community, with families. But something else with our outreach in the different areas, we were able to kind of tie some of the different areas here at the health district and things we're working on. Our emergency person here, Andy, was able to get 80 units, air purifier units, but he was really having a hard time distributing those out in the community. And Daniel suggested, why don't we get in contact with Children's Village? And so we were able to give out the 82 units that he got from DOH, and 46 of those went to Children's Village. And I don't think if we would have had that partnership here, that we would have thought to reach out to them. So during the wildfire season, when so many people were struggling respiratorily, it was really nice to be able to give them some help. And Jessica here in our office works with the SNAP Ed program, and they're looking to create some community gardens in our areas. Wapato reinstituted a garden this last spring. I was able to get a hold of our SPED teacher in Wapato. She had kids out in that community garden. Jessica had a new, has some funding available to put in more gardens in different areas. I was able to send that out to schools, and Davis Sela and West Valley are interested in using those with their DD programs. It's a great place to get students an opportunity to get out working in the world, working with the community. So we're really excited about the possible partnerships that might bring us as well. We are increasing our communication to families by outreach, by events, and we had a very successful event at the beginning of this last month. On October 3rd, we worked for 6 months putting this event together. We partnered with Pacific Northwest University. They have a new occupational therapy building there, a new program, and it was a perfect combination of us working with DD clients and they're working with occupational health. We had over 35 different providers that offer different services to the developmental disability community, and it provided a great opportunity for people to learn about different resources in Yakima, some that they had never heard of. And so it was a really great program. We also offered 2 educational sessions, one on applying for Social Security. If you have a child that needs help, they really need to apply for Social Security in order to be able to get a lot of the other help, as well as it helps to give them some income as well. And over 60% of people that apply for Social Security their first time are denied. And then if that happens, you usually have to get legal help to help you refile, and it's a big headache. And so they were able to offer us a session, and one of the sessions was on applying for Social Security successfully. And we have an agency that helps families do that for no cost, as well as we had Central Washington legal aid there talking about guardianships. So some really great information for our families, things that they just really desperately need. And Victoria is going to play a little video that we were able to take that night.
So my name is Daniel Bravo. I am a transition specialist for the Yakima Health District. When someone comes in tonight, I want them to see that there is a lot of things available to them. There's a lot of resources available. There's just not a lot of knowledge about them. Some of them aren't well known, so people aren't getting the access because they don't know where to go.
Yo le recomiendo a las personas que vengan a este tipo de eventos si tienen un familiar o un hijo con necesidades especiales, porque no todos los lugares dan información y ayuda para las personas que son parte de la comunidad a pesar de sus discapacidades o sus impedimentos.
So the idea was to bring in all these different companies and organizations here in one spot, so they all have a central location to get access. And with all these different organizations, all here to serve and try to communicate with these different people about what they do and what they can do for all the individuals that need support.
So it was a great partnership that we made with PNW. They were very happy with the event. They want us to feel free to use them again. And I think it's going to be great for our community. We're going to work at trying to have this event every year. In addition, we are still working on enriching our See Abilities campaign. We've gotten some additional marketing pieces done to provide to our employers, the agencies that work with the developmentally disabled, because we don't have a lot of employers still in the Yakima area for clients to get jobs. And so we also are we've added one story, one testimonial to our website from Liberty Bottle. We're adding one to Powerhouse Grill, as well as one with the Eagles. And we just got confirmation this week that a manager from Safeway is also going to speak. So once we've got those up, Amanda, I'll be back in touch with you. Okay. And we will work on trying to get some more employers in our area that would be willing to employ our DD clients. So our future plans is, again, working with employers to help support job opportunities for our DD clients. And Daniel wants to work on developing a transition network for the teachers in Yakima County with a monthly meeting and or newsletters. The teachers are really tough to reach, and they really need the resources. They really need to learn more about how the process works. And we will continue to develop our event, A Journey to Success, into a yearly community event. So our program and the transition program, it helps with our strategic goals to deliver our mandated services, develop a network of community partners, and increase the effectiveness and the efficiency of the district services. Questions?
For your employment, do they threaten any of their funding sources if they're getting Social Security disability or SSI payments and they work? Are they getting penalized for working in terms of income?
We could, and we have resources that we can send them to that can look at their picture, look at what their Social Security is, and make sure they don't work over a certain number of hours so that they don't get their social security.
So for those employers that hired developmentally disabled, are they subject to minimum wage laws or is there, okay, it's the same
They most
rules?
Certainly are. They most certainly are. They did away with the sub-minimum wage a few years ago. And so anyone that is employed must be employed at least at minimum wage. And we have some employers that have had employees for several years that pay quite a bit over minimum wage. It's really neat. I invite you to look at that See Abilities website and look at the interview with Liberty Bottles. They have 4 different individuals that are working with Liberty Bottle and they're wonderful, as well as in another few weeks, we'll have the one from Powerhouse Grill and you better get your box of Kleenex with that one because that one is really cool.
For some reason, I thought that there was a funding source that followed that person with that employer, so that like half the salary was funded by the provider or something. And so the value add was that you providing a job opportunity for this individual, but there is some cost savings there.
There's some work opportunity tax credit dollars that once you hire someone, you can apply for and get some reimbursement for hiring. I'm not sure that it's ongoing, but I know that there are definite benefits for hiring someone that it can offset a lot of the upfront costs.
Cecile, follow-up. I know, looking at the presentation, a lot of it was geared towards, kids in high school transitioning out of, school. But it seemed to me that the program is also available for older people, say. in
Oh,
their
yes.
40s, et cetera.
Oh, yes, our regular DD program, our employment services are for anyone 21 and older.
Okay.
So that was always my main focus when I came on. And transition has become more important in our state because a lot of the kids are kind of falling through the cracks. Or what Job Foundation does is it gets them engaged and hopefully in a job sooner. Because if they don't go through Job Foundation, they do have to wait until 21 to get the funding that funds them a job coach to help them at age 21. So a lot of times, what we don't want is the kids graduating to the couch and waiting for a few years to start services. So that's why that Job Foundation program is so important.
Thank you.
You're welcome.
I have a question. You mentioned that schools are not meeting their transition goals. What does that specifically mean?
Well, they're required to teach transition and they're supposed to be working with students to have a good solid plan to help them with employment. And just a lot of them don't really understand the process and know how to do that. So that's why our outreach to the schools has become so important to help them learn, also to help them with Job Foundation to hopefully get their students on the right track and so they can meet their goals.
I have a question. So can the Job Foundation be part of like an IEP or something?
Interestingly enough, the schools are now asking for Daniel to come in and be a part of their IEP meetings to kind of help the families. And so it's something that we can help them with, especially if they're in Job Foundation when they're nearing their end of their school days. We can help them if they've done the Job Foundation document, they've got those goals. They've got that information that they need to complete those final IEPs for students.
So Cecile, in essence, what you're doing is you're training the schools
Helping.
to accomplish their goals.
We're helping them as well get hooked up with DDA and DVR that offer these programs to help the students.
That will help in the process as well.
Cece, are they not statutorily required?
Say that again, please.
Are the schools not statutorily required?
They're required, but do they always meet their metrics? Not always.
Well, I think that's the thing that I was struggling with too, is that like the schools are mandated to provide these services, right? And so the health district, we've looked and we've identified a gap that it's failing, frankly, our students. So the health district is coming in, trying to be a connector to help the schools with the external stuff when the schools are supposed to be doing it from the get-go.
Right, Commissioner Curtis.
And then the students that do engage with the health are Daniel, right? We hold this individual's hand throughout their cycle and their life, right? Like if the job opportunity doesn't go well, the health district is going to stand there and help try to find the next steps. And so
We
you're,
don't do that, but our providers do that. We fund the providers to work with the student. And for example, say Jeffrey works at a job and he really doesn't like it, or it just doesn't pan out. They can go back into the system and work on finding them a new job and giving them training all over again. And each individual, whether it's a student or adult, once they've got their job coach, they're assigned a certain number of hours a month that they can work with the job coach. And hopefully the employer can also add some supports from their office to help them too. So the job coach typically isn't with the client every day, every hour that they work, but they go in, they work with the employer and say, okay, is Jeffrey having any struggles? Or does he need to take some additional training? They'll help them take the training. So they've got a certain number of hours a month they can spend with the client to assist them and keep them on track.
Any other questions? If not, then we'll move on. Thank you very much. We'll start with our agency reports, starting with our executive director, Mr. Pasco.
Thank you so much. Good morning, everyone. It's nice to see a full house. And before Cecile leaves, I do want to share my appreciation. I'm really humbled by her service, and she's representative of the type of staff we have here who really commit to these programs. So thank you, Cecile. I appreciate it. I wanted to also share that we do this program. This disabilities program is really in partnership with the county. And so we're doing on behalf of the citizens and as a partner that we can. And really, this is part of our Catalyst model, is facilitating the kind of change that you all indicated. One of the things that's hardest, I think, and this is not a personal experience, but my understanding from families who have children who are differently able, is the concern what happens when they're not there to shepherd the child through adulthood. So the beauty of this program is it's not just helping those children become adults, and as Commissioner Lee said, as adults be self-employed, but also helping those families know that they're not alone in this journey, which can be very complicated. So it takes a long time, I think. And one of the realities of managing the bureaucratic process through government is that you have to unlock the benefits. And so that's also part of this educational journey for our staff, to explain to folks what is available to them, because it's complicated. And so navigating that is part of what Daniel and Cecile do. So I'm really grateful. But again, this is representative of the work that we do every day here at the Health District. So I really am humbled to work with folks like that. I wanted to just also share my appreciation that we do have all of our board members here, since we will be discussing the potential for adopting a budget, which again, we're always grateful for your consideration early in the process. We have good news around our audit, and also we've been monitoring things that you'll hear about more about the difficulties that are happening in our neighboring counties, Benton and Franklin, around H5N1 and avian bird flu. So we're trying to stay abreast of that so that we're prepared in the event that something happens. I did have some specific things to give you updates on. One is that our legal representative of many years is going to transition away from us to bigger and brighter things. We are looking into representation for the Health District in the future. So Chris Mertens, who is certainly been our rock with respect to our work with Kate, and someone that we're engaging and discussing potential opportunities with, because we do need to have legal representation. So that's something that I'm working on with Bob. Also, I wanted to give you an update on the fact that we will be representing the Health District at the City Council meeting, Yakima City Council meeting, November 12th, discussing the City Council's interest in harm reduction and regulations around harm reduction. We've been invited to speak on the benefits of this program. We've met with representatives already, and we've had discussions on that. James has been involved in that process as well. So we feel strongly that the harm reduction program is beneficial to the city of Yakima and is there to serve not only the needs of those who require our services specifically, but also to keep things like dirty needles off the street, naloxone distribution, and so forth. So it's a study session, and again, we've been invited to speak on that. that's all I had to share on that unless you all have questions.
I have a question.
Yes.
If you're going to be discussing the benefits, are you also going to be talk about acknowledging the unintended negative consequences reduction? I think it's fair to provide a balanced approach. Because there are certainly circumstances in which we are seeing an increase in overdose deaths. Having gone right along with our law enforcement officers. In fact, I just had a meeting yesterday with the police chiefs, and there is an intensified frustration with the inability to engage really meaningfully with those clients to harm reduction services to get them into treatment, and they are routinely using Narcan several times a day, sometimes on the same people at various times. And the strength of the drugs that are being distributed are growing so strong that the community who is using these drugs are relying on Narcan so much though that it is proving to be ineffective in just a single dose. And so there's a concern among the emergency responders, fire and law enforcement that there's some unintended consequences here that need to be addressed. And I know we're doing the OD mapping, which is incredibly important to fully understand it. But I do think, and I know we have a representative of the city council here, but I do think it's important to acknowledge that there are some aspects of it that are causing some unintended consequences that our emergency responders are having difficulties with trying to grasp, how do we get around this issue? And certainly I'm very proud of the work that the health district has done as a board to determine that we want to actually make sure that engaging for treatment, because that's truly how we can try to get these folks off and out of that addiction that afflicts them, because it's certainly many stories, and you can talk to anyone who responds, that as soon as I witnessed it myself, we came upon someone who overdosed, Narcan was administered, they were put into the back of the ambulance. A couple seconds later, they popped up, kicked open the door, and ran down the street refusing services. And unfortunately, the Narcan wears off, and at times they can still succumb to an overdose even after having that administration. I just think it's something that we have to acknowledge, and I'm not proposing a solution, but I do think it would be fair for the health board in their representation of the program to talk about how are we going to get around the issue that people are still though using these illicit drugs, and intervention and treatment has got to be a priority.
Yes, well, Commissioner, one of the things that we really are committed to is making certain that first responders have as much naloxone as they need. And that's been something that we're recognizing, is that the dosing is not enough. They need multiple doses sometimes. So that's something that we're looking at. But I'm trying to follow along, if you don't mind, because the unintended consequences of providing this service, I'm not following, because really we're responding to the fact that, as you indicated, the drugs that people are using are far more potent, so it's having a far greater effect. And so we're just trying to avoid multiple deaths on the street. That's really what our focus is.
I think what I'm trying to say is that I think it would be helpful to acknowledge though that harm reduction on its own, it needs to be coupled with the intervention and the treatment, because absent of that, what we're seeing is repeated use of Narcan on the same clientele until such time as, unfortunately, no one is around to administer the Narcan. So we have to find a way to have, if this truly is going to be a successful program, if harm reduction is going to be successful, then it can only be, I think, successful if we can point to it being successfully a tool to get people away from the addiction and away from the drugs that are routinely putting them at a point where they could succumb to death, because it's just a matter of whether or not, when we came upon this person, it was simply because we were doing a sweep of alleys. That person would certainly have passed away if it hadn't been for that. So this is something that we need to bring forward. It's not as simple as providing Narcan. It has to be our opportunity to intervene. And I think it is important for the health district to be a strong voice in public health policy to say that if we're wanting to drive towards saving lives, then the distribution of these harm reduction services has to be a place where people have interaction with treatment and the option and influence routinely and regularly to get to that treatment opportunity.
I think it's great that you say that, but and that is something that the health district does. We have comprehensive out there every Thursday here in Yakima. And we have the tribal behavioral health services out there in Toppenish every Tuesday, along with substance use disorder options and behavioral health. They also, Catherine's team also hands out Narcan out there, as well as her nurse practitioner is also doing, I think it's buprenorphine or Suboxone out in the field right there at harm reduction. Unfortunately, we don't have the resources for that here in Yakima, but this is a much huger issue. Even most health insurances will cover for 30 days of treatment, which is not long enough for somebody to stay sober when you release them back out into the
Facilities
community.
aren't there, and I appreciate that we're doing that, and if you recall, when I started on this health board, that wasn't something that was happening. And this board decided that it was something that we wanted to see happen. We want to have providers there so that when someone is interacting with someone, that they're actually interacting with someone who's trying to convince them that they're worth investing in themselves and their family loves them and their community cares about them, and we want to see them get out of this state of addiction. It's
We've
really
been doing that through our Hub and Spoke program with, in partnership with Comprehensive for probably 6 years.
And were we tracking it? I mean, we can go over the data.
Comprehensive,
No,
yes.
Well, I think, oh, I'm
Oh,
sorry.
no, it's okay. At this point, I'll just comment on the fact that you're coming to city council. I can't say a whole lot because I sit on the council. The question came up when one of the council persons asked about the effectiveness of the harm reduction services, specifically around needle exchange, I think is what it was. And there's been a lot of discussion since then and questions answered, but it gives the council the opportunity to hear from the health district what they're doing and how they feel that is beneficial to the community. And that'll be helpful to council, but also council will have questions about it. And the major question is really, do we have the ability or the authority to direct another agency in terms of what they're doing? And we likely, I want to be cautious here, we likely don't. So then it becomes a question of, within our jurisdiction, what will we allow? So that's really what, kind of what the issue will come to, so.
And I'd like to thank Commissioner for explaining your perspective, because I do think that it's a beneficial program because it is full service, as you. And it's full service in many ways. It's harm reduction in terms of reducing the spread of communicable disease. It's harm reduction in terms of distribution of naloxone. So if people are in an overdose situation, they can be administered. It's certainly about educating people about their options and the access point for behavioral health services and programs like Suboxone. So it's exciting to have such a robust program, and that's certainly something that we intend to communicate. The reality is it's difficult for people to engage in and agree to recovery. I wish it was more simple. And I also wish that it was easier to find and retain staff for that, which is complicated. But you're talking about just the things that concern us every day. So that's what we'll communicate.
If I could just update board, one of the problems with the use of these drugs, the additives, first there was fentanyl, and now there are compounds that are not reversed by naloxone. And that's just adding to the situation. Some good news, the supply of fentanyl is decreasing. They're limiting the materials, the raw materials that are coming out of China. They're getting them, stopping them, and they're also capturing the pills that are assembled in Mexico and distributed. Except in the Pacific Northwest, our numbers are not falling, but the rest of the country, fortunately, they are, and perhaps that will continue. Unfortunately, it leads to the substitution of fentanyl with these other compounds that cause the same kind of high that aren't reversed by naloxone. So I think the problem will remain. All we can do, I guess, is reduce it. And I think that's really what harm reduction is. Reduce the problem. It's not always possible to eliminate it. But if you have fewer deaths, fewer people using, you have a smaller problem. And this is true in many diseases that we can't get rid of them, but we can reduce the complications and reduce the number of people that are suffering from them.
Can I add something as well? On the reservation, some of the problems too is that, because we really try to engage and get people when they're coming in hot, we're just like, well, let's try to get you to treatment. A lot of our barriers have been, is that many of these people need detox. In this area, there's not a lot of detox. Plus, that's added to a treatment facility. So we are sending people on the other side of the mountain or, different states from time to time. And it's not cheap. Most insurances. They'll do some insurances if you have insurance, but a lot of them don't accept Medicaid and they want to do these sliding fee scales. And if we have a person coming off the street who absolutely has nothing, we're doing a disservice almost. But I like the idea that we are doing the harm reduction, going out into the community. And the way I see it is that we're not going to turn anybody away. I mean, we have people who go to treatment, I don't know, 3 or 4 times, and my bookkeepers, they're going insane. They're like, well, how many times do we have to fund these people? It's like as many times as they need. And at some point, hopefully the recovery bug will kick in and they'll live a more healthy life.
Yeah, I think the statistics that I remember is that most people quit 6 to 8 times before they're successful. So that's a number of interventions. That number's probably grown.
The sad reality that I've accepted is these are folks who are voluntary wanting treatment, right? But we have a huge segment of our population that doesn't want treatment. And when you have first responders constantly showing up, providing a service, it's costly. But at what point do you always have to provide that service, so.
I think law enforcement, yesterday in my meeting, it was represented to me that right now when they respond on an overdose, you have EMT, you have fire, you have law enforcement. The estimate locally is it's at least $1,000 every time. And so it's $1,000 to have that interaction with an individual and then repeat that when they're saying that they're sometimes in the same day or multiple times a week with the same individual. Obviously, there's other, draws on the system as society, whether or not, there are fires started and then there's garbage cleanup and there's all of the tertiary things that come with it. So, the harm reduction to the individual, but we're perpetuating harm on society. And I think perpetuating harm on the individual, the further away we get from being able to have people, it's a law thing, to your point. We're going to have to decide as a society if we are willing to take that step to say to someone, we're going to put you in treatment if you don't want treatment, because professionals have been able to assess that you're not able to make that decision, clearly for yourself because you're in the throes of addiction. Those are civil rights questions. Those are deep thoughts, right? But I think we can all say, though, that, the problem is not getting better. It is extremely costly. And the most costly thing are the lives, as you know, that are not going down, being lost to overdose. They're only increasing in our communities. And I just don't think we can accept that what we're doing isn't working.
Maybe a model on those calls where a mental health provider is part of the team responding. You have fire, you have police, you have health, ambulance, and a mental health provider, because ultimately the way you talk to people matters. And I've seen interactions that were poor and interactions that were terrific, and the only difference is language in those two. So I don't know. I realize there's not enough mental health providers. That's problem number one. And getting them in situations where they're responding in potentially dangerous situations is problem number two. So I don't know. I don't have a solution for that, but maybe looking at a model in which it's not so law enforcement based, but instead mental health based would be a better model to intervene with success rates that were a little higher.
We do have a DCR.
Yeah, the commissioners have actually funded fully the DCR request. So we do have a goal of having a designated crisis responder both in the lower valley and the upper valley, 24 hours a day, 7 days a week, 365. But it still continues to be, what are their abilities legally to actually say.
Right.
I thought we had Ricky's law that was supposed to.
We do, but it's such a touchy area. It's much easier to detain somebody with mental health than it is with SUD because it's easier to prove the imminent harm. an immediate risk of immediate death or yourself or others. Even from a payer perspective, with mental health, the average length of stay when you detain somebody is around 10 days. With SUD, it's 2 to 3 days. So you get somebody for 2 to 3 days. By the time that you're required to let them leave, they're likely gonna been able to change their thought process or engage them in enough treatment to.
Well, it's illogical to think that we can change their thought process in such a short time period. These drugs are so powerful that they only have to use them 4 times and they can't say, it's not a.
Well, that goes to the revolving door.
Yeah,
They have
and that's
to
why
want
it
to.
can't be something where we're relying upon them to make the decision, because they physiologically cannot make the decision. They need it.
But what we're talking about mostly are legislative changes that need to occur.
And judicial precedent.
Yes.
Well, on that note, we've talked about this before, but some adjustments to the Involuntary Treatment Act would be a good direction. But of course, yeah, we need to change those rules a little bit so we have more latitude.
There was a law that
We
was.
need to, but then we also need to have a place to put them.
There was a law that was recently passed just this last legislative session that it allows for people to be, what they have a mental health issue where they are able to create a plan with their loved ones where while they're in a state of clarity, they can say, you know, if I end up in a certain situation, I'm giving permission to not listen to me while I'm in the state of having a downward spiral in my mental health or addiction affliction. And we're hoping that that's something that can be a tool to be able to, if someone has a known mental health issue or disorder, that it would allow a greater opportunity for intervention on that case to hold them for longer.
And a lot of it just goes back to more resources too. There are several people that if you're at harm reduction and we were able to say, we can take you to a detox bed right now, they would go. But in 2 days from now, they're not ready. It's so off and on like that, and you've got to wait a week to get a detox bed. That now you've lost that person. It's.
Law enforcement has offered it while they're on the streets and there's no place to put them.
There is the acute care detox that are available and their beds open there daily at CTC. Those are never full. But it is the revolving door because people don't.
They can walk out anytime they want.
They can. If they're not detained, it's locked. I mean, they have to get out, but they have the right to leave when they want. So typically people will stay until they start getting the withdrawals, the severe withdrawals, and then will choose to leave and go use. Or, you know, people are smart and, you know, I'll feed anybody. So they'll come in for a shower and a meal and a bed and it's a revolving door. And that's okay because at some point, maybe they'll stay longer and maybe you'll get them longer and it'll be eventually you'll build the relationship enough that maybe they'll be successful, but that is not used. And
Well, that is where the use of our judicial abilities and our state laws need to help us provide services or even mandate services that are really going to help get them beyond that point, so they won't have the freedom just to walk out, but in long term get the treatment that they need to move out of their addiction.
Well, one of the things that, as was indicated by Edie, the interaction with someone and letting them know repeatedly that things are available to them, I think matters. And so that's one of the things that we pride ourselves on is reaching people where they're at. So that's one of the reasons that we're grateful for the expansion and the partnership with the tribe to be able to reach more people, to your point about getting them into addiction, getting them to different circumstances, helping them understand that they're valuable and that they deserve to lead a different life, to reducing the impact, as you indicated, on emergency response systems, our first responders. That's all part of why we're doing what we're doing. So it's helpful. Again, I wish that we could wave a magic wand and have it disappear immediately, or flood this community with every resource that we need, but we're not there yet. So I'm grateful for the conversation, and we'll learn more from our meeting with the Yakima City Council. Are there other questions on this issue?
when is the study session?
It's,
12th.
Remember this
12th of
podcast,
November.
at, I think, 5 o'clock.
5 o'clock, study sessions are 5, regular council 5:37.
Okay, thank you.
Yeah.
This next issue, it revolves around some changes that we're making in terms of our exempt staff and also me personally. So I want to make sure that I explain it well. If I don't want to overcomplicate it. But I wanted to share that, when I first came to the health district, our staff were on a 20-step salary scale, which I thought was pretty high. We reduced it to 10. And for our staff who are part of unions, we created pay for performance. So if you essentially, your job is to do your job well, and you are paid accordingly for that. We don't have a current salary step accommodation for exempt staff. And so I wanted to share with you that Ryan and I have been working on this with James, and also under the direction of Mary Byers as our board chair. Our goal has always been, especially with our directors, is retention. And so our goal is to have people have a long career here. We want them to be supported well, take care of their loved ones, but also to retain their expertise and all that we've invested in them. And I wanted to share with you that while we're interested in that, we also recognize that these are tough times for people. And this has not been an easy year or couple years for people in our valley. The costs are rising for people. Costs of regular business services are up. So we are providing services to people who are often very modest. So normally around this time, we would be talking about whether I receive a salary step increase. And so I'm sharing with you that I'd like to forego the salary step increase this year. What we've been discussing is the idea that, again, from a retention standpoint, we have created a policy for our exempt staff, which are directors, managers, coordinators, anyone who's an exempt position not represented by a union, that once they reach the step 10 level, and I'm the first to reach that as an exempt staff person, they would forego their next annual salary with the idea that if they then stay for 2 years, they'll receive a 2-step increase. The goal is retention, and the goal is to create a fair system that everyone is accountable to and everyone has the privilege to receive. So the idea would be that you skip a year and then you have a year where you receive a salary step increase, you skip a year, and so forth. So again, one of the reasons I'm bringing this to your attention is I think that it's important for me to lead by example. I'm the first person to receive the step 10 level as an exempt staff person. So I'd like to forego a salary step increase this year. The distinction I make is that while our staff who are exempt work under the direction, me and the administrative staff with Ryan, I am privileged to work with you. And so you are the ones that decide whether I receive a salary step increase. So that's one of the stipulations that we talked about with James, is that whether I receive one or not is dependent on the board approving that. And so that's the distinction that we make between exempt staff and me specifically. But I share with you that I recognize that it's a tough economic period for many people, not only in this county, but in this country. We are running into people having difficulties financially all the time. I don't think it's appropriate for me to take a salary step increase this year. But I open that up for discussion, and I'm happy to go into some specifics about the the policy that we've created, but it's essentially a policy that I thought was necessary. So it was equitable. It wasn't based on favoritism. It wasn't based on seniority. It was just simply once you reach a certain threshold, then you're eligible for that. I hope I've done it justice. Ryan, James, is there anything else?
Andre, is there a COLA adjustment that our exempt folks get regardless of a step increase?
Yes. So
Okay.
we have COLAs built in. That's something that's been part of our operating model for many, many years. So that everyone's eligible for that, but the salary step increase would not continue this year.
Well, I'll just say that, having conversations and through this process, that I think it's they work very hard at making it equitable to both exempt and union staff. They've also recognized the value of people that work for them. the opportunity the health district offers in terms of cross-training and advancement and all the things they do to make the department, the whole staff function as a whole, I think has been exemplary in a lot of ways. I've talked about this a lot of times. I've not seen many agencies that do that as well as the health district does. So I want to commend the health district on their work in that area and the coming up with a policy. You know, it's very difficult. The city deals with 9, 10 unions, something like that. The county does as well. So you know how difficult those things can be. So when you're trying to make it equitable to your exempt employees and union employees both, to find a way to do that based on their enjoyment of their job, the benefits to them on the job, and then the performance that comes out of that. We've seen the performance that comes out of that. I just think this is a solid plan. I think it recognizes, and so I think the goal is to retain staff because they spend a lot of time training staff. So I think this is going to help move them in that direction. So.
Just to give a little more perspective, some perspective on training and environmental health specifically, it takes generally about a year to get an environmental health specialist completely trained and working independently across that program. There's so many regulations and rules and policy and processes that have to be ingrained in an individual to be effective and accurate in the field. And in the world of being a regulatory authority, being accurate and consistent is everything. So, you know, it takes a long time to get people trained up effectively. So, you know, retention is vital to our success.
And I should mention also that our pay for performance plan for our regular union staff remains the same as it always has been. This is just to maintain the integrity of the program and also to avoid the appearance of favoritism. So, and I want to also thank our directors for embracing it as well. So each person who reaches that threshold will go through the same process.
Just one question,
Yes,
from, not specific to you, Andre, but in general. By holding a step increase at 1 year and then giving a 2-year step increase the following year, there's no net savings there, for anybody, economically. So if the principle is that we're in hard times and we're trying to make savings, giving somebody a 2-step increase at the end of 2 years, there's no net savings there. So I guess my question is, what's the point if you're doing it once a year, or if you're doing it 2 times as much in 2 years? There's no savings there.
Well, I think the goal for us has been always retention. That's one of the things that we've talked about. You know, the idea that we're also benefiting. I think it's important. I think there's a tendency also when you're looking at exempt staff who are salaried, that you are going to benefit in a way that others don't. And so one of the things is that there is an immediate pay increase for pay for performance for union, but for exempt staff, there is not. So essentially, if you want to receive step increase, you have to serve longer. And so that's a retention model. So that's important for me because again, this idea that you would arrive at a certain threshold and you automatically keep getting step increases. There's nothing after step 10 right now for our exempt staff.
Sure, and if the model is for retention, then that makes perfect sense. I guess I was misunderstanding whether it was to generate net savings or whether it was to generate retention. So if it's retention, that makes perfect sense. Otherwise, I don't know that it makes any sense, but I understand what you're saying.
No, the money's minuscule.
I'm sorry, there is some savings as far as economic net present value of money. You know, $1 today is worth more than $1 tomorrow.
Got it.
So there is some savings there as far as that goes.
Andre, why wouldn't you just have pay for performance for your exempt folks? Because usually it's really hard to get pay for performance in the union side. So I was thinking that since you had it already implemented on the union side, you'd obviously have it on the exempt side, but I guess that's not the case.
Well, to put it bluntly, I have high expectations. I have high expectations for myself and I have expectations for our staff. So we may have union members who don't have a great year in terms of performance, who may not meet certain standards, who may not exceed at their job. And so they can receive a gradation or a percentage of a salary increase. My expectation is that we have to provide great service, exemplary service at a high level, high output. It's a hard job. Can be a 24/7 job. I mean, full disclosure, I ask a lot of our team. I try to give them a tremendous amount of support in every way I can, but I ask a lot. And so the expectation is 100% service all the time. And so I think that deserves to be rewarded. I wouldn't be comfortable providing our service to you as a board. And at a certain step level, but I also recognized in fairness that that could be seen as favoritism if an exempt staff person was receiving a full step increase as opposed to a percentage step increase. But again, you can use me as an example. If I had a bad year and you thought I deserved to get a 1% step increase instead of a 3%, I wouldn't be doing that. So it's either you do it well, or other options. So I share that with you because, again, if you ask any of our team, they know that when we come ready to do 100%, 110%, whatever our example is of full service. That's what we expect of our exempt team. And also, they're not only providing services to this board and to our staff, but they're providing services to this community. And this is a very, very difficult time in our nation's history. It's complex, and we've had multiple emergencies. We've had multiple responses around environmental health that are now part of our portfolio that we never intended. So we now ask more of our directors, frankly, than we did 5, 6, 7, 10 years ago, because the portfolio is massive. And Chase is a perfect example of someone who has to manage multiple funding streams that just didn't exist 10 years ago. And so we have a tough job, and I want to pay it well, but I also have expectations.
Question on Grace. So you talked about exempt employees in year 11 and 12. What happens in year 13 and beyond?
Oh, yes. So it would just be that same process. You skip a year, and again, another good year, you get a 2-step increase. Then you skip again, then a 2-step increase. Then you skip again, you 2-step increase. So you haven't made more money. Again, smarter people like Chase would say that you haven't kept up with inflation, but essentially you haven't necessarily lost dramatically, but you have made a commitment to a longer, I think, period of service and retention. But it is exactly as you said, it's year in, year out, year in, year out, for as long as you are retained. So any questions for me, or we're happy to answer things outside of the meeting as well, but that was the plan, and I didn't want it to come as a surprise to you because this would normally be the time when you'd be discussing my review. So that's all for me, unless you have questions.
So I just want to comment and thank you for being willing to take the lead, be the role model for others coming behind you. All right, next on our Chief Operating Officer, Ryan Adler.
Okay, our emergency preparedness report, our Yakima Health District White H5N1 work group continues to monitor the situation going on in Franklin County with the all the cases that we've had over there and also across the country. You'll be hearing more about H5N1 from Dr. Vargas and Melissa. We also continue to monitor the Mpox clade 1B and Marburg viruses outbreaks that are going on internationally, and then which you'll hear more about also. But we do continue as emergency preparedness, it's just making sure that we're prepared for that and monitoring the situations. Also, the Yakima Health District hosted a 24-hour HAZWOPER training, which is a hazardous materials training. It's the 24-hour training that our staff does. It allows our certified staff to stay safe and provide assistance during hazmat incidents that affect public health. So now we've had staff go through that training, so they're able to identify hazardous situations in public health. Our positions, we have filled our advancing contracts coordinator position. That person will be starting in a couple of weeks. We also have a gal at the front desk who is an office tech that has been promoted to Melissa's group as a public health tech position in community disease control. which then we have the domino effect. So now we had an open position for an office technician, and we also had a position open in environmental health. And we've been advertising for those positions. Those close on Sunday, and we'll be doing interviews in the next week or two. So we'll have a couple new staff at the next meeting that we'll be able to introduce to everyone.
I think it's also important to show, like, just kind of following up on what we were just talking about, like the number of applicants and qualified applicants that we get. When we chose Juliana to be promoted, we had, these are entry-level positions, and we had people with bachelor's in public health degrees applying for these, and I believe we had 18 qualified applicants, and we dwindled it down. But how many do we have for the office tech coming in?
Office tech, we had about 19 for that one.
Yeah, if I could comment, I just recently was introduced to the majority of the staff that works here at the health district, and I would say that you guys on the board probably don't realize that we are the Los Angeles Dodgers of health district.
That's funny.
Yeah, right. The team is pretty deep, and I was impressed, actually, person by person by person. I was like, wow, you guys got a whole lot of people here and they're all pretty talented. So I just kudos from an outsider who is not, hiring anybody, but instead just witnessing the situation and looking at, boy, that's a pretty good team. And I'm impressed by them and what you guys have put together. So it's really quite something. Retaining them is important, obviously, because when you're the Dodgers, people want to pick off your players. So
Yes,
not
that
having
does
bias.
happen often.
Yeah, right. So that's something you have to face. But anyways,
Hence a retention program.
yes, that's the retention program.
Actually, I do want to share with you that that is certainly an issue, and I don't know if you all recall, but there was a point years ago where the State Department of Health were offering 100% remote work, and so it really created a disservice to keeping people locally. So, and then we're finding this also, that we're becoming a clearinghouse for private industry as well. So thank you for your awareness of that.
Well, for anyone who's turned away, we need. They're considering a career change. There's lots of opportunities in the.
In the city as well.
I can say we have no engineers on staff, but I do recognize also when you bring up a great point. Commissioner McKinney.
And attorneys while I'm at it.
Yeah.
Believe me.
Always attorney.
Believe me, they broke the mold with James. But yes, hiring people with that qualification level, that experience level, it's very, very difficult, as many of you around the room recognize. And keeping people here long-term is not easy either. Not everybody realizes that we have tumbleweeds or, brush fires and things like that, or really complicated weather patterns. And it's not for everybody. So we're really glad to retain our staff. I didn't mean to take away from
Okay.
Ryan, but it's a big deal.
Yeah, so I think we need to move on so that we don't lose any of our staff members to.
We're recruiting.
All right.
Oh, my goodness.
All right, that's all I have.
All right, thank you. Any questions for Ms. Ibach? And now we'll move on to our map report from Chase Ford.
Good morning, everybody. Moving into the month of September, we'll be reviewing. Before we get into that, I'll just a quick update on our audit. We are experiencing a 3-year compliance audit as of now. The auditors were actually in the building a few weeks ago. So the majority of the field work has been completed. Right now, we're going through what they say call manager review. So the auditor's work is being reviewed by their particular manager. So that's where we are with that right now. As of now, there is no real concern. There's nothing that needs the board's attention, so we're really happy about that at this point. So still in the audit, so quote unquote not out of the woods. However, everything's is looking well, trending in the right direction. Getting into September's financials. For the month of September, we had a $184,000 gain, bringing our excess for the year to approximately $1.5 million. For our allocated budget for revenue, that was 8.8 million, and as of the end of September, that's coming in closer to 10 million. For expenditures, our allocated budget was 9.4, and our actuals coming in at 8.6 million. Any questions on the summary page? Moving into the income statement, experiencing the same trends throughout the year. There really isn't nothing new, so to speak. If there you have any questions, please let me know. The largest, we had a large gain in the month. The biggest piece of that is for our MAC revenue. I've been talking about MAC throughout the year. So that is continuing to be another chunk of revenue that we've been receiving. We got $126,000 in MAC revenue this past month, or for the month of September. I do expect that to slow down. That will not continue on. We are during COVID falling into arrears. Yes.
You define MAC for me.
Medicaid admin claims. That is linking people directly to Medicaid services. So a lot of our nursing staff, a lot of our community health are doing those type of activities. They have what they call random moment time study. There's a email that goes out and they have to explain exactly what they're doing in that moment that is connecting somebody to Medicaid or not, depending on what they're doing. And then we have a financial report as far as what funding is supporting that person while they're doing that particular work. It's actually very complicated. It actually kind of.
I believe you.
Federal reimbursement.
It's
Yeah.
federal reimbursement for highly compensated employees, i.e. our nurses, more or less. There's a lot to that. There's more to that. That is a very simplified, boiled down version of that. Essentially, it's activities linking people to Medicaid is really what that program is for. And again, we've fallen into MAC arrears billings during COVID. We are now getting caught up. I expect there to be continuing to be a good amount of MAC revenue through this year, but in 2025, that I don't believe that will be the case. We will continue to get MAC revenue. It is a quarterly billing. However, it is not going to be to the tunes of hundreds of thousands of dollars. During COVID, we were doing a lot of Medicaid linked activities, and that's why it was such an uptick.
Medicaid activity contract.
Medicaid administrative claims.
There we are. Yeah.
And if I may, when we say into arrears, the state actually works on behalf with us. And so there's a state person. When we say arrears, the state was in arrears.
Yeah, the whole system kind of came to a screeching halt, so to speak.
And that's not just public health reimbursement, that's other
Well, including meeting mandates.
Unless there's any specific questions, again, there's very similar trends to what we've had all year. Unless there's specific questions, I'm going to move on. Moving into the next page. What I would like to point down is the FPHS funding for 2023 funding. There was something a little bit unexpected happened this year in the month of September. Our FPH funding, which is $3.8 million, that gets up to this point has been come to us in two chunks, 1.9 and then 1.9. Generally one in the current year and the one following next year. But this year, the way the consolidated contract is ending in 2025, they've completely funded the FPHS. So we've received $3.8 million in the past 6 months. So there is going to be a major uptick within our reserves. And then year over year, we've been carrying over because we've played this game every year just about because we have a little bit, it's a fiscal contract. So we carry over some money for fiscally from the fiscal period into the calendar period. That's been to the tune of about $400,000 the past couple of years. It's going to be over $1 million at the end of this year. I just wanted to give everybody a heads up on that. That is a deviation of our normal practices, our normal operations. When that first happened, it was like, oh, whoa, DOH made a big mistake here. They just sent us $2 million when they sent us $2 million 4 weeks ago. And so we contacted DOH and like, no, this is how we are paying this out because 2025 is the end of the consolidated contract and we'll be starting a new one.
Okay, so are you allowed to put those excess funds in interest-bearing accounts?
They are as we speak. Yeah, absolutely, 100%.
Chase, when do we know when we will have the 2026 onward consolidated contract signed and know what those funding sources will be moving forward?
Soon.
Okay.
Soon. I imagine we will be working through that in the next few months. Those will be in the new contract will be signed before 25, as I expect. It's all controlled by DOH, but I would expect that to be signed before we go into 25. It is a little bit of a different situation because it's a multi-year contract. They're actually talking about making it like a 5-year contract, which would be kind of easier because of situations like this where there's contractual things that don't quite make sense or something like that. Makes much more sense for this money to come in the segments that it has been. However, this is the way the contract is.
And Commissioner Curtis, if I may also, this is specific to our state since we have a biennium budget. So it's the end of the biennium budget, new budget, governor, the whole thing. So that's really what's motivating this, which is uncomfortable for us because again, we're not just moving money from one contractual period to another, but it looks like a loss on paper when it's not, it's being funded. So we just want to make certain that the board understands that we're not in charge of how this works. In fact, we worked very hard to make sure it was calendar year budget, but they didn't.
Is there any questions? We're moving to the next page. Looking for programs, again, I am not gonna, mention anything specific. Our play section has been our FPHS. Down in the Peach section, kind of there in the middle is at 295 Medicaid admin. You'll see $126,000 of revenue this year. We've generated over close to $350,000 for that particular program. Again, I don't expect that to be happening year over year. This has been a catch-up year for that. Next page,
So bioterrorism 120, like, is that like an every year program you have?
Yeah, that's our FEVR program. Yeah. Gosh, bioterrorism is a little bit of a legacy term for that, but it is our emergency preparedness. Yeah.
This hurts to look at.
I just downloaded a magnifying app to see if that would.
I can,
Read this.
yeah, it has gotten really small. We've added a lot of programs year over year. I will break this into 3 pages. That would probably help out.
Yeah. Help a lot of us out. Thank you, Chase.
But it is not, the challenge is to try to keep them all in the same colors on the same page.
You are right, it has gotten much smaller.
Yes.
Yeah, we've added a lot.
Now I can't focus, now that you say that.
Yeah.
Oh, here we go.
Yeah.
Now it works.
So I will make sure that is a little easier to read.
Thank you, Virginia.
It's fine, use your iPhone. Well, hopefully you can read this without having to use a magnifying glass. That would sort of be helpful. You'll read this. And again, moving into the next page, again, I'm not anything necessarily specific to note on here. Okay, last page is our cash flow. And as I was speaking to a minute ago, we had an uptick in our cash reserves. 1.5, $1.6 million. And that has to do with the FPHS funding. We will be carrying that funding into 2025. If there's any questions, I can please report. Thank you.
Thank you. Thank you, Mr. Porter. If there are no further questions, we will continue. Next is our health officer, Dr. Navarro.
Prepared as much as realize you're doing the meeting. You're gonna blend in for a while. Plenty to talk about the value that we put in public health infrastructure. The appropriate time to do so. Just to recap some of the things that were done in the last year. We've had the fire and power problem taken care of as best as we could. Large outbreak of syphilis, which is nationwide. One of the outcomes of that level of care is a test and treat program where people came in, they might have had signs or symptoms of syphilis, they got a test drawn and they got treated up there. And I think that's had an impact on the congenital syphilis cases, which basically disappeared. So people are no longer out there waiting for a test result and then not being able to be found and treated. They're getting treated right when the opportunity presents itself. We've had PFAS issues, we've had nitrate issues, we've had landfill fires, we've had E. coli in well water, we've had H5N1 in poultry, cattle, and now people in Washington State. And I think that's just a small number of things that have been done and dealt with, and you've all heard about that in various meetings. So without that public health infrastructure, all these things might have run right. We have a TB program that is dealing with more cases this last year. And we've had several outbreaks where a person with contagious form of TB, multiple people that were exposed to that, turned positive with their TB test, and several people have active disease, and they're all being dealt with because we have a good team of TB nurses. And we still, we do this every day. We deal with it. So all of this leads to safer and healthier Yakima County. I'm going to move on to some different topics that are intertwined, but some stand on its own. We talked about last meeting with vaccines, and we also talked about antimicrobial resistance, more vaccines available, more antimicrobial resistance available. And at first glance, you might not think that there's any relationship between the two. But it turns out that widespread use of vaccines will probably reduce the amount of antibiotics that are needed. And that's because viruses damage tissue, and damaged tissue is more easily infected and by bacteria. And once they're infected by bacteria, more antibiotics need to be used. So vaccine turns out to be one of the more effective ways of diminishing unneeded antibiotic use. I say unneeded, if they didn't get the viral infection, they wouldn't get the bacterial infection, they wouldn't need to get antibiotics. So it is a way of defending against multiple antibiotic-resistant bacterial infections. You've probably seen in the news, there's been a new outbreak of infectious diarrhea associated with quarter pounders. And if you needed a reason not to eat fast food, besides it's inherently unhealthy and calorie rich and cholesterol rich, this is another good reason.
I don't think it impacts the new chicken Big Mac though.
Tastes good though.
So this is an example of the way that CDC collaborates with EOH, which collaborates with the local health jurisdictions. So these cases were reported, and most microbiology laboratories, if they get a culture from stool, there's a test for pathogens. It's a battery of tests. And one of the pathogens that's in that battery of tests is for E. coli OH157. Now, that probably doesn't mean much to everybody, but that's the cause of hemorrhagic colitis from eating contaminated food. Now, for those of us who've been around long enough, you might remember in the 80s and 90s, a big outbreak caused by the same organism that was traced back to Jack in the Box griddle. And the griddle had uneven temperature. So some of the hamburgers were getting cooked to the right temperature that would kill the E. coli, and some of them weren't. And all that work was actually done in the state of Washington by University of Washington gastroenterologist Bill Carr, who has since retired. But that laid the groundwork for all the subsequent studies to be done. And in one of the classic way of dealing with things in epidemiology is to do what's called a case control study. So cases are identified. Let's say in this case, there were, I think, well, quite a little bit less than 100 different cases, several of them requiring hospitalization and a few deaths, which is similar to the previous outbreaks. So the cases are the ones that have gotten the disease. They're interviewed and various exposures are identified. And then they interview people that didn't have the disease in a similar location. And that's how a quarter pounder was identified. So the people who ate quarter pounders were more likely to have the disease than similar people who didn't eat the quarter pounders. They tested the meat extensively at over 900 locations in 13 different states. And in no case did they find that the beef was negative. They also tested other components of the quarter pounder. And unlike some of the other hamburgers that are served at McDonald's, the quarter pounders always have onions. And the shredded onions aren't cooked. And it turned out that that's where the E. coli came from, the onions. And a lot of this has to do with the concentration of supply. So instead of like buying some onions down from the lower valley, onions from all over come to one distributor who then chops it up and sells it to the fast food places. Onions have been eliminated from food in Taco Bell, KFC, Pizza Hut, and Burger King because of the knowledge of this outbreak, which all has to do with good public health infrastructure. The disease that ends up killing people is a result of getting the infection is called hemolytic uremic syndrome. And it puts people into renal failure, and they usually die of complications of that. A quarter of all the identified cases have gone into the hospital. And the ones that developed renal failure were the 2 patients who are the ones that passed away. So that's kind of a classic example of the use of epidemiologic tools for figuring out how outbreaks occur. And the obvious result was that people got rid of the onions. The bigger socioeconomic thing is this need for efficiency in the drive to consolidate. So if you're a fast food restaurant and you want to get things going as fast as you can, and if we used more things locally and didn't buy things, well, you know, we're not buying them, but businesses that use things locally are less likely to suffer from this contamination that occurs from bringing things in from all over the country and consolidating them in the factory. Taylor Foods, I think, was the one that ended up being the distributor of these onions, and they have recalled all of their products as a result. So.
Can I add to that just real quick?
Oh, and I wanted to say that because of our food safety services, much of this can be prevented. Go ahead, John.
Yeah, and through our reporting systems that we have, we were notified within minutes that the contaminated onions were found, where they all went, where they were distributed, because they're able to be tracked in batches, and we were able to identify. We specifically here in Yakima County didn't receive any of those contaminated batches of onions. But if we had, we would have been able to know exactly what location that food went to, so we could go there and make sure that that product was pulled. So, you know, it's pretty efficient system that has been developed, you know, through the federal, state, local levels, that we're able to know and respond and get food out themselves within probably an hour.
And to continue with gastrointestinal illnesses, there is a disease caused by a bacteria called C. difficile. And that disease causes diarrhea. And sometimes it can be so bad people can die from the complications of this disease. It's directly related to the use of antibiotics. And interestingly, just recently, University of Pennsylvania researchers have developed a vaccine for C. difficile. And with the use of that vaccine, the complications from that C. difficile infection will be greatly reduced and perhaps prevented. Again, overuse of antibiotics is linked to the increase in the number of cases. Hospitals deal with this on a regular basis. There is often a case in the hospital that's severely ill. And sometimes, unfortunately, people die from that, despite the fact that we have treatment for it. So vaccine technology, again, is going to help out in a very difficult problem caused by bacteria that emerge because they're resistant to antibiotics that are commonly given to people. So with that, I'll move on to H5N1 update. The 2 known cases that were in Missouri that didn't have clear poultry or cattle exposure initiated concern about the possibility of human-human spread. There's various pros and cons about whether this did represent truly human-human spread. The interesting thing is that the onset rate, symptoms indicating exposure happened at very close to the same time, which could indicate that each of these people was exposed to something at the same time. For instance, a wild animal that we, said in previous meetings, many different animals carry H5N1 and may disseminate. So both these people may have come in contact with an animal or animals that are carrying disease. They haven't been able to prove that. All the healthcare workers that were exposed to those Missouri patients, one of them went into the hospital. none of them have now tested positive for H5N1, indicating that the fear of human spread has been dampened a little bit. So, last week in California, there were 15 new cases, and we've had 2 poultry workers infected now, confirmed, and 5 with presumed infection, all due to poultry exposure. Interestingly, when they sequence the virus DNA, it's a distinct strain. The poultry strain is different from the cattle strain. And just what that means in a simple sense is not that much, but in a broader sense, co-infection could cause a problem. So as happens in animals, if one strain of influenza that maybe is highly pathogenic and another strain of influenza that's not so pathogenic, gene exchange occurs when the co-infection occurs. And if this happens with H5N1 and they get they're able to exchange DNA with a virus that spreads rapidly, you now have a virus that originates in cattle and sheep, or not sheep, but cattle and poultry that people are working with. You now can have the possibility of human dissemination. So the more people that get H5N1 as we move into the flu season, the more potential there is for developing a spreadable strain. Fortunately, to date, that has not happened. That combination of co-infection with recombination occurs every year, and that's why new strains of influenza pop up, and the vaccine is reformulated every year based on what happens in Asia, since Asia always sees it first, and then it spreads through birds to North America and South America. A new tool has been developed by CDC where they have a blood test that specifically can test for antibodies generated by H5N1 infection. So that gives us the ability to do much broader serologic testing of people who may have been exposed but are asymptomatic. So conceivably, if you go in with a very easy to do blood test, you could monitor and follow a group of people to find out how far this can spread without having to do cultures or diagnose people that have been exposed that haven't actually had symptoms. So it's another tool for epidemiologists to figure out how this thing is going and perhaps get on top of human spread very early on. Increasing numbers of cattle herds continue to be affected in different areas of the country, meaning that the virus is widespread and gives a lot of opportunity for these exchange of gene events to occur. Getting back to public health infrastructure and food outbreaks, the quarter pounders aren't the only problem. There were waffles and pancakes outbreak, pre-prepared, that you would put in the toaster, and listeria has been associated with those as the same organism that was found in the pork's head meats. And this really goes back to, like I alluded to initially, the manufacture and distribution of foods, and things that are pre-prepared have the highest risk. The things that you don't cook, because there's a kill zone about 165 degrees. You know, if you have salad and you think it's contaminated and you heat it to 165 degrees, you have mush. So I always thought that those triple washed buckets of salad were safe. So, but you're actually safer if you buy your own head of lettuce and cut it up and wash it yourself. Then those people are going to, I don't know what I'm going to do, because it makes salad, putting together a salad, very easy. So I may go back to lettuce here. Maybe when's the last time you had a wedge iceberg lettuce with Russian dressing on?
Russian dressing?
Yeah.
That's memories. No.
No, this is going back to like going to El Gaucho. So the pre-prepared foods are available more and more widespread, and the more they're handled, the more their chance to get contaminated. So, you know, if you go to your local butcher and he's got Ellensburg beef in there, and he's the first one to touch it, that's going to be a lot safer than from a big factory that gets meat from all over the country, puts it in the packages and sends it out to the stores. So I'm all for buying local. I'm going to find out how many places do that. And You know, in the US, we like to think that we have the safest food in the world. Well, we do, but it's still not that safe. Be careful. Cook from scratch. All right, that's the end of my report. Any questions?
How effective is the influenza vaccine currently available in October for H5N1?
It does have some effect on it. Obviously, it's not as good as the targeted strains that vaccine was manufactured for, but if one got H5N1, so I think people have, you probably won't get as sick as if you didn't.
And is there any cattle vaccination program?
I don't know. You know, people who interface with the state agricultural, and I don't think there is.
Well, on that note, because there is, to my knowledge, there is no death associated for cattle or poultry, and they get over this now. They're increasingly getting over it faster. It was about 60 days for them to recover, and it's closer to 30 days now. But there's also no risk of drinking milk or eating beef and having the disease transferred to you. So I think if you're talking about food supply, it's important to note, though, that if you are a consumer, you shouldn't be concerned about catching this disease by eating beef or drinking milk.
Milk's got to be pasteurized. There's a big fad about whole milk, you know.
Some grocery stores that sell pasteurized milk.
I just want to make sure that we want to not set the fear factor out there for people who are concerned that they shouldn't be having milk or beef anymore because of this.
We've talked about that in the past. They've studied beef extensively, and there's no evidence that it's transmitted. And whole milk, you know, the other animals that hang around milking facilities like cats, they drink the raw milk.
Those are smart cats.
And the cats get it, yeah. If you like cats, it's bad. If you don't like cats, it's okay.
Yes, Commissioner McKinney, actually, 100% correct about the fact that especially cattle are coming down with essentially an illness. So the real goal has been, and not public health's goal, but FDA's goal, really, Department of Ag is working on the separation or isolation of those animals and really helping local farmers understand, cattle people, what the goal is and how you can determine who's ill and who's not, since they live community.
Birds do die. That's how they do. That's one of the two ways they do surveillance. They gather dead birds and test them. So,
It's interesting that, we have a law in Washington state that eliminates, especially for seasonal workers, it sets a limitation on 40-hour work week. And what has done is it has caused folks who are in the agriculture community to find multiple employers. And how this strain actually was discovered because it was transferred from an employee who was working at one place and then had a second job at another place. So, unintended consequences are many of that. So important to bring up.
yeah, that is a big point, because that's basically how COVID spread, is by healthcare workers working in one place where it was, and then going to their next job. And it really facilitated spread. So that's exactly what's happening too in the cattle and poultry industries.
I'd like to speak a little bit to the issue of and the value of tracking, because I don't know how many of you remember this, but 20 years ago, we had an incident of mad cow in the United States, and it happened right here in Mapton, Washington. And I was a dairy farmer at the time, and I'm spending a lot of time with the press, with the Wall Street Journal calling me, and just crazy stuff, Boston Globe, Portland and Seattle radio stations. Anyway, it was nuts. But the thing that really ultimately saved us was the fact that the system, they could track back into exactly where that affected cow had come from.
Canada.
It was from Canada. That's right. So it wasn't us. It was from Canada. And we avoided, by that tracking system, we avoided a lot of the panic that happened in Great Britain when they had mad cow on a much larger scale. But this was able to be pinpointed and isolated and dealt with really effectively. It was pretty cool to watch. Anyway.
Yeah, I recently went on a tour of the Lower Yakima Valley Guama, wasn't for the purposes of H5N1, but a piece I took away is we stopped by one of the dairies to look at a new lined manure lagoon that one of the dairies had installed. We couldn't even step foot on the property. We had to look at it from the road. We couldn't touch the fences. We couldn't do anything. They kept us at a very great distance due to their safety protocols they've installed or implemented for H5N1. So it's good to see that the dairy operators are taking it seriously and taking measures to keep the cattle healthy and not bring that problem into or that issue into Yakima County if they can help it. So they're doing well.
So in closing, you're getting good value for the money you're spending. And we thank the board for your support.
Any other questions or comments for Dr. Bard? Thank you, Dr. Bard. We will move to our disease control, Melissa.
I'll just follow up on the H5N1. We are actually up to 6 cases in Washington State, and there's still the CDC. Good news is there has been no proof of any type of human-to-human transmission in human cases. We can't confirm that that is human-to-human. But I think it's also important to acknowledge that there were 800,000 flock that were euthanized due to this outbreak in the Benton Franklin County. And then also I think it's also important to note that we did a lot of work several months ago in preparation for H5N1 should this happen to our county, especially because of the large amount of dairy cattle farms that we have here. And because of the hard work that we did, we were able to share our workflow or plan in the event that this happened with Benton Franklin, and they have used our plan that we created with our ICS team internally. So I think the preparation, just what we did with our team, has really helped have an impact on Benton Franklin. And then I wanted to talk about the OD map. I presume that was signed on Tuesday last week.
Last Tuesday, yeah.
Yes. Yes, so great. So our contract should be getting finalized with OD map so that the health district can pay for ImageTrend, the interface for first responders for fire and for fire departments when they go on overdose calls. So we'll be able to have more tracking information on overdoses within Yakima County. And Dr. Barg is correct. We have a lot of TB going on right now. We're currently managing 7 active TB cases, and we're still working on contact investigations for those. And just for a little reference, we usually have about between 5 and 10 cases is our average active TB cases per year. It really slowed down with COVID. People weren't getting health care. They were being misdiagnosed because there was other respiratory illnesses going on. So people assumed it was COVID when in fact, or pneumonia, when in fact it likely could have been TB. So our cases went down, but we are seeing a big increase right now with the cases. So we'll have contact investigation going on with cases being identified who are positive, but we are still trying to rule out whether they have active TB, current disease, or if they're just infected with something that we call latent TB, which means you're not contagious to others. So we're still working through that process. We've been doing our RSV and flu monitoring through, what's going on nationally, statewide, and then locally. It's pretty low right now throughout the nation, state, and locally. The flu season is not really picked up or really kind of started yet, so that's good. And then just also, you might have heard that for the E. coli outbreak that's going on right now, you might have heard that there was a case in Washington State. I just wanted to clarify that was not something that they did not eat at a McDonald's here in Washington State. They ate at McDonald's in Colorado. They just happened to be Washington State residents. So I had any cases from a McDonald's here in Washington State. We've also seen an increase in our overdose deaths. Last year, for October, for year to date through October, we saw 76 overdose deaths, and this year we're at 106, which has surpassed the 96 total overdose deaths that we had in all of 2023 last year. So something that we're definitely monitoring. It's also something when we see or hear of what seems to be a more potent fentanyl or drug that's come to our community. Right now, we're hearing of a small little light colored purple pill that's on the streets that seems to be really potent. We're also notifying our harm reduction clients and encouraging them to change their drug use behavior, making sure that they have Narcan and really educating that community on what's going on out there. I think that's about all I wanted to talk on, other than I wanted to give the floor back to Andre to talk about WSPHA.
Oh, put on the spot. Well, we're members of something called the Washington State Public Health Association. We're also part of WSAFO, which is the Association of Local Public Health Officials. But WSPHA is sort of the partnership arm that brings together academia, social services, other government agencies, and public health. And we normally have an annual meeting in Wenatchee every year. That's been in 12 years now. It's been in Wenatchee at least. And so it was hosted again here. And I wanted to share that there was a record turnout in our community to the tune of over 900 people in the downtown area. It was at the convention center, which again is a great venue for that. It was packed up to find parking, and people were really complimentary of Yakima, of the services provided in the community, not just our health district. But it was really well attended, perfect venue for that kind of effort. We were able to introduce Dr. Atterbury as our reserve health officer, so he was able to meet with the State Department of Health Chief Science Officer and State Health Epidemiologist, certainly supporting Dr. Atterbury in his journey for training as a reserve health officer. And we had staff who were able to assist in that entire process of welcoming people, helping people set up and so forth. We had great projects. Lily can speak to her team with presentations, but it was really well represented. And I wanted to share my gratitude to all the staff here at the Health District who participated, because really I continue to get compliments about the caliber of the people that we have on staff and their level of service and their enthusiasm for this work. So it was really a great event. I don't know, Lillian, if you want to touch on some of the things that were discussed, but we presented on a number of issues, so it was great.
Yeah, just as a reminder, as I had mentioned last month, we presented on PFAS, the work that's going on around the surveillance that's being done to further identify PFAS in the SELA area, as well as the outreach work that's being done in collaboration with, I think it's called Pursue PFAS Free. So a unique model in terms of outreach that we have here in Yakima that we wanted to make sure that others are aware of, that it's hard work, it's slow work, but it's effective work to be able to actually talk to people one-on-one on something as confusing as PFAS, because it is evolving and it's changed at least 3 different times since we've done the work itself. So that was something, Dr. Atterbury, thank you for attending that session as well. That was appreciated. And then the other session was around the work that our team member Erica Ochoa has done around overdose prevention, but also the opioid or substance use prevention work in the school. So presenting on the breadth of work that's been done over the last year, not only to increase naloxone access, but to work with the community coalitions in the school to prevent substance use overall. And I know that was well attended as well.
So one of the things we were able to highlight with a lot of this is as Melissa had indicated, our commitment to creating new systems and approaches to service, and then sharing those so they can be replicated throughout the state. That's been done with Guama, certainly with our PFAS work, with our work around reaching folks at harm reduction, certainly what we've been able to accomplish in preparation for emergency response. The other thing I wanted to share plainly is that a lot of people in public health are aware that we have complexities that we're addressing here, the public safety, or rather public service power shutoff, power safety public shutoff. The euphemism that the electric company was using, but essentially the fact that we went through some really tough times with fires and drought and high heat, wind, and concerns. I'm really grateful to be able to represent Yakima and show people that any great city, any great county is complicated, and we have our share of things that we're addressing. But it's still a vibrant place. It's still a very welcoming place, and it really was nice to see people joining us. And that WSPHA conference will be back next year, if not the year after. So it was really well attended, and it was nice to see everybody. Thanks for putting me on the spot, Melissa. I appreciate it. I hope I did.
Chase on the spot too.
I hope I did justice.
With the chief finance officer.
Yeah, it was actually really neat though. The Department of Health had what they were there. So their vital records team came over and toured the building. It was really neat to be able to do that tour with them. They were very impressed with our check-in system and how things flowed up front. They made the comment that we were doing this better than King County, so we were really I'm happy about that. We actually were able to chat with them a little bit. It was a team of about 4 one-on-one with them and just talk through some of the issues that we have with our different systems. And so there was a lot of good conversation. They had a lot of good questions. The DOH Vital Record team was very impressed. When they asked for recommendations, our Yuritsa, our front desk lead, had a couple of suggestions, and all 4 of them took their pads out and wrote down her suggestions and her issues. I was very, very, very proud of that team. We also had the CFO of DOH come. Amy Ferris is her name. I've been working with her for 7 years now. We actually talk quite often, but this is the first time that we're actually able to meet in person. So she was here. I gave her a tour of the building. A lot of our staff at that time were actually at the conference, so there wasn't necessarily a lot of people here. But I was able to introduce her to my staff, my team. And it was a really great visit. We've been working closely for a long time now. And so, again, just very proud of our team and humbled to work with them. Yeah.
Thank you. Anything else, Melissa?
I'm just very proud of the team and I just wanted to make sure that I shared all that with you.
Well, we appreciate that. Thank you. All right, we'll move on to then our environmental health with Sean McGee.
All right, good morning, everybody. So I'll start with our solid waste program. We are pretty much complete with our permit review for the DTG limited purpose landfill. As you all know, they're developed a new cell with a liner and leachate collection and drilled several more groundwater monitoring wells. Their application was a measly 3,900 pages. So I think Steven, our solid waste lead, deserves a day here soon. But our review, it went really well. We're waiting for Department of Ecology's official recommendation on the review that they do of the same application. So we'll be meeting with them soon to go over their findings, our findings, and the hope is have a clear path forward on writing a new permit for the DTG landfill. So I expect some things to start moving in the next couple weeks. And then based on Ecology's findings, we'll huddle up as a team here at the health district to discuss some specifics around the permit and what that'll look like. So making some real progress with the DTG landfill. Moving on to Caton limited purpose landfill. As you all know, we're approaching the appeal hearing with the Pollution Control Hearings Board. That is scheduled December 9th through the 13th. So we're working with Christopher Mertens, our attorney on this case, to get everything in order and all the talking points that we're expected to present at that hearing ready to go.
Sean, when is the hearing?
December 9th through the 13th.
It's a long hearing.
That's what it's scheduled for. I don't know if it'll take the whole. Yeah, they reserved 5 days for it. So
There's a lot to talk
cover.
about.
Yeah.
Yes.
There's
A lot of history.
There is a lot of history.
We've been waiting patiently for a long time.
Yes. So in the meantime, they are still operating and we're just going through our process and the legal process to try to deal with all that. So and then next week, we'll be down at the Natural Selection Farms composting and biosolids site. They have a unique liner system that's primarily a clay lime layer that's, so many feet thick. The Department of Ecology was taking a closer look at that liner system. And they've been very accommodating and welcoming us on site, and they're going to do kind of a fitness test of that system to show that it's adequate, or what adjustments they can make to continue forward to protect groundwater in that area, because Lower Valley does not have a lot of restrictive layers and has high groundwater table. So they're taking it just as seriously as we are in that, it's a necessary step to make sure groundwater is being protected. So excited for that site visit. I haven't been on site there before. It sounds really interesting. That's where all the waste from hop harvest go to be composted and, you know, be turned into fuel for other things. We're excited for that one. And then we are working on our septic program around the new septic regulations that are coming out in 2025. Specifically around operation and maintenance of septic systems, and then the property transfer inspection requirements that are going to be implemented in a couple of years. We want to build a process that's simple, easy to navigate, and is efficient for community members in Yakima County. We don't, you know, want to hold up progress around land development or people trying to sell or buy homes. It's a complicated process already. We don't want to necessarily hinder that or get in the way of it. So we're trying to build a really efficient program.
So just to be clear, this is the legislature adding another inspection requirement for property transfers, which, if I'm not mistaken, adds to the cost.
Yes. It is a mandate that is now in the new septic regulation. So we're looking at best ways to do that. Right now, there has to be a certification process for operation and maintenance professionals. That currently doesn't exist in Yakima County, but we're trying to get an efficient and affordable certification system in place.
So another opportunity for anyone who didn't get hired here, they and become a licensed inspector, because yes, we're just creating all these rules and the positions to fill that role, they're not there.
Yeah, there's probably going to be conversations with your background. Would be helpful.
You can imagine that the home builders and developers and realtors and even insurance carriers are all very interested.
Excited.
This. I wouldn't call it excited. I would say perplexed is more of a descriptive word. Just continue to drive up that cost.
Well, you can pay for it now, or you can pay for it later. You call in the groundwater.
Homeowners do have the opportunity and should take responsibility for testing their own water and septic on their own. It's actually advisable to do it once annually. And so that's certainly that the public has the freedom to go and do on their own. Because I agree, as someone who lived on a well, I did that, but it is up to the homeowner. It's called buyer beware. That's what we have.
Yeah, and moving forward, the health district, we don't carry any authority over exempt wells or individual wells that are privately owned, and well, there really is no regulation over those, but yes, the recommendation.
Thanks for giving them the idea.
I don't know if that's even possible, but yeah, the recommendation is sample your water annually. And then pump your septic every 3 to 5 years.
Public service announcement, that was good.
Anyway, I'll wrap up there.
Sean, do you know if, on your previous comments, if there's any Airbnb developments for the manure lagoons in the lower valley? It would be a real draw.
I don't think so.
Any other questions? All right, thank you, Sean, very much. And we now move to public health partnerships with.
Thank you. I'll give 2 updates today. The first being that it's still flu season, so we're still working to get flu, to update our flu website, as mentioned, with yakimavaccines.org. So any location, any community-based location where we are offering, and by we, I say the DOH Caravan, is offering the flu and COVID-19 vaccine, there's a list available there. We also maintain a list of pharmacies and the cost of the COVID or flu vaccine, depending on their insurance. But in addition to that, given the H5N1 outbreak in Benton Franklin County, we've been asked to place a special emphasis on providing the flu vaccine specifically to those that are working in ag, specifically dairy and poultry workers. So we're going to be partnering with Tractor Supply in Sunnyside to host a flu vaccine clinic every weekend, starting in November through mid-December. And again, being able to provide that flu vaccine, given that concern around co-infection and just in general, it's not a good flu vaccine. While we're there, we will be providing information around H5N1 to those that are there. That way they know to be aware of what the symptoms are, what the current situation is. But again, it's not one vaccine for H5N1 it's the flu vaccine, and if they're there, they can also get the COVID-19 vaccine if they choose. So we're happy that Tractor Supply was willing to lend us their parking lot for every weekend. in the next couple of weeks. Outside of that, last weekend, we were able to work with Safe Yakima Valley. They hosted a shred and meds event. We also provided the firearm safety, firearm trigger locks and firearm lock boxes to people that attended. We took 100 of each, thinking that would be enough. We actually ran out. There was a far greater demand than what we were able to provide. So again, that was a nice surprise that the resources were wanted by everyone there. But it just points to the fact that we need to continue to reach out in the Lower Valley specifically to make sure that we can get resources out consistently, along with the relevant education on how to safely store your firearm. And that's usually done in collaboration with the local police department as well. There were, I went through my updates. Any questions? I kind of get going and I said, oh, that was
Just on the
it.
flu vaccine, it's being offered free to anyone, right?
Yes, yes. And that's honestly why these are hosted. Most children are able to get the flu vaccine for free. It's the adults where there's a gap. So if you're uninsured, there is a cost for people to get the flu vaccine if they don't have Medicaid or an insurance. Which is very high in our community.
Lillian, you had mentioned also the medication tech bag was a success as well with this program. So with your meeting.
Oh, yes, and also in Yakima specifically, we had other team members that were working with the community coalitions that was the shred and med, that was the meds portion of the shred and meds event. Because last Saturday was the National Take Back Day. So here in Yakima, there were 3 events that were hosted, one in West Valley at the Wilco, one at the Yakima Valley College, with the help from the students, and then also at Fiesta Foods. They were able to collect a total of 50 pounds of medication that we were able to divert to be safely destroyed. And so that work was done in collaboration again with the community coalitions here in Yakima. I know that there are other community coalitions in Wapato, Highland, and Sunnyside that also had events, but we were at the ones here in Yakima specifically.
Any other questions, comments? Thank you, Melissa. All right. I'm sorry, Lillian. Yeah. Melissa, same way. Okay, we're gonna move to unfinished business, and the first is the 2025 budget hearing.
Okay, so we advertised notification of the budget hearing for this meeting in the Yakima Herald and on our website, and we had a copy of the budget out at the front lobby for the public to see. I did not receive any comments about the budget. I don't know if any of our guests have any comments. That's what they're here. Any comments on the budget? No, okay, so. No.
I guess I'll formally open the hearing. We can ask the same question.
Okay.
Do we have any comments? And nothing from the public.
Nothing from the public.
Then we will close the public hearing. Thank you. So we have a proposed motion.
Yep, so there's proposed motions to adopt the 2025 proposed budget.
Board?
And
I
a
move
motion.
that we adopt the budget.
We have a motion. Do we have a second?
I'll second.
Thank you. So we have a motion second to adopt the proposed budget for 2025. Because it is a public hearing, let's take a roll call vote on that, please.
You want any discussion beforehand?
We can. Any discussion? We had no comments. I didn't think.
Okay. All right. Okay, so if you approve the budget, please state yes. If not, please state no. Commissioner Lindy.
Yes.
Dibble.
Yes.
Aileen Ackerman.
Yes.
Councilmember Carrillo.
Yes.
Dr. Atterbury.
Yes.
Stephanie Algren.
Yes.
Commissioner McKinney.
Yes.
Commissioner Curtis.
Yes.
Catherine Saluskin.
Yes.
And Mayor Byers.
Yes.
10-0.
So motion passes 10-0 and budget's adopted. Thank you very much. We appreciate that.
Thank you very much. Well, good.
And we'll move into new business. City representative update, citizen representative candidates.
Okay, so we advertised the citizen representative position at YV Cox and a couple of different notices to all the cities. We did receive 2 applicants for the city representatives, Mayor Byers and Councilmember Carrillo. for the two that applied. So it would go, since those are the only two candidates that received for the two positions, it would go in front of the Board of County Commissioners for an official vote and then to move forward. So that's an easy one. Moving on to the
Does it
citizen
require a motion to send it forward by the board?
for the two.
I think it is part of the process.
Yeah, you still, I think you.
Okay, we still need to,
Okay.
still need a motion then to move those
Yeah,
two.
we will accept a motion. Would like to do that.
Motion.
Thank you.
Second.
Thank you. So we have motion and a second to move the two names forward to the county commission.
Mayor Byers, may I request that you call for abstentions, just in the event that the Board of County Commissioners who are present on this board could choose to abstain to be part of that secondary process.
Okay, let's do that.
Okay.
Yeah.
So if you're in favor of moving the two candidates forward, please state yes, if not state no. Commissioner Lindy.
I guess I should abstain.
Staying.
Okay. Edie Dibble. Daleen Ackerman,
Yes.
and then we have Councilmember Carrillo. She would abstain.
Yes, so that's a.
She would have to as well.
Yes.
Same with Mayor Byers.
Mayor Byers will.
You got 4 people voting,
Why not
5
abstain?
people voting.
Okay, Dr. Atterbury,
Yes.
Stephanie Algren.
Yes.
Commissioner McKinney
Abstain.
and Commissioner Curtis
Same.
and Catherine Salutskin.
Yes.
I counted five.
5-0.
5-0.
Yes, thank you.
Good job, team.
I can use my fingers there. So thank you. So it's forward.
Okay, moving on to the citizen positions. We have 2 positions that are available. One's the at-large position currently held by Dr. Atterbury, and one is the community stakeholder currently held by Stephanie Algren. We did receive 6 candidates for the at-large position. 3 of those candidates would also like to be considered for the stakeholder, community stakeholder position. So we have a total of 6 candidates. In the past, what we've done is if we have a large candidate pool, then we'll narrow it down to who we want to move forward on the interview process. There are 6 people total for the 2 positions. We'd like to interview all 6 of them. That's something that we can move forward with. Or if we want to narrow it down from that 6, then good too, also. There will be a vote at the next meeting. Once, what we'll do is we'll do the interviews, we'll record them, send them out to the board members, and then we'll actually vote for the top candidate and then an alternative that will go to the Board of County Commissioners for a final vote on.
Mayor Byers, I don't feel that 6 is too large of a number to offer an opportunity to interview for 2 positions, so I'd be supportive of interviewing all 6.
Any other comments or suggestions by the board? And then do we have consensus or agreement that we would interview all 6 and forward them?
I think so.
All right, thank you.
Okay, and then what we can do is more than happy, there's 6 interviews, more than happy to do the interviews, record them, and then we'll send them to the board members.
Okay.
How we want to move forward with the actual interviews.
Are we not going to have members of the board participate on the interview panel?
That's up to the board and how you want to do that.
I think it's important that members of the board participate. We've done so in the past.
And what we've done in the past, for like, health officers, we've done a commissioner, a citizen and a city, member, as part of the panel, at three members. And then we record them and send the board member to the board. So if we want to do that.
So that would be, the other option would be to have board members involved. So what are the thoughts of the board?
I think the board members should be involved and obviously I'll abstain from my involvement. I'm one of the citizen candidates.
Was that the way we did it the last time? We had an interview panel of 3?
Yeah, so we had you, Mayor Byers, and Daleen were the 3.
And that was for our,
Reserve
health officer, so.
We know we can't have 2, we can't have 2 or more commissioners, since that would make it.
Right.
But aside from that, that's an obvious.
I think that was a great group. I nominate the slate.
Same slate. Second nomination.
So we have a motion and a second. Nominate the previous slate of interviewees.
I mean, if I may, are we nominating the commissioner or commissioner, city representative and individual?
No, I was nominating the people who actually feel those.
I see.
For the
Keeping
interview
it
process.
My second was to that, right? So just like.
Cutting through the circuit and just getting to the point.
Very direct to the point.
Who were they?
Let me ask, first of all, Commissioner Lindy, are you available for that?
I am, yeah, and for the record, I was. So not that I didn't remember doing the interviews in the health office, I was thinking back to the city council or when we did the health board members 2 years ago. What we did, so. Anyway.
Yeah, so actually what we did for that was we had open public meeting where all the board was available to come to that and
Okay.
do that. But it also worked out well with a committee because we recorded and sent people, so. So if we do have more than 5 board members, then we have to have the open public meeting.
Are you available?
I believe so, yeah. We would look at I think I should be.
So as long as you're working with us on a calendar, I would be available.
Okay, yeah, and the goal would be, do those interviews before Thanksgiving, get those sent out to the board. It'll probably be, 3 to 5 hours of watching videos of the interviews. We'll have plenty of time to watch.
So we have a motion on the floor.
It's been seconded. That was comment.
Okay, that was coming. All those in favor, please say aye.
Aye.
Opposed? Aye, no, I'm just kidding.
Abstain.
And we have one abstention. So motion passes. Thank you.
Next question though I have is questions. So the questions that will be asked.
Oh, yes, so we do have 11 questions that were asked on the last time. I sent them out to the board members and if they would like to look at them and have any suggestions, we can do that. We'll get that out right away so that we can work on this.
Thank you. All right. Is there any other discussion of that? If not, we'll move on to adjournment. I'll entertain a motion to adjourn.
Motion. Second.
So your motion and a second to adjourn. For our next Board of Health meeting again, December 4th, 2024. Remember, there's no meeting in November. We meet in December on the 4th. All those in favor, please say aye.
Aye.
Any opposed? And we are adjourned. Thank you very much.